Hi, I'm Dr. Wes Fisher, Director of Cardiac Electrophysiology.
Hello, I'm Dr. Jose Nazari, a cardiac electrophysiologist.
Hello, I'm Dr. Alex Verro, cardiac electrophysiologist.
Atrial fibrillation is a condition that results in rapid, uncontrolled heart contractions. It is the most common rhythm disturbance there is. It affects 2.4 million Americans. Today, we want to talk to you about what atrial fibrillation is, what causes it, and how it can be treated.
We believe that the more you know about your condition, the better prepared you will be for its treatment. And with that knowledge will come greater confidence and peace of mind.
Now, before we talk about atrial fibrillation, let's take a step back and look at the normal functioning of the heart.
The heart is a muscle whose function is to pump blood through the body. It has 4 chambers, 2 upper chambers called the right and left atrium, and 2 lower chambers called the right and left ventricles.
Each of these chambers has a different function. The left ventricle pumps the blood out to the entire body, from the heart to the head to the toes. The blood returns through 2 large veins, entering the right upper chamber called the right atrium.
From there, it passes to the right ventricle, which pumps the blood to the lungs. The blood then returns to the heart from the lungs via the 4 pulmonary veins, which drain to the left atrium. The left atrium is then responsible for filling the left ventricle, completing the blood flow circuit.
The contraction of the heart muscle is driven by organized electrical impulses, much like a spark plug drives an engine. The normal heartbeat originates in a pacemaker-like structure in the right atrium, called the sinus node, and it spreads evenly and uniformly through both the right and left atrium, causing them to contract. The upper chambers, atria, and the lower chambers, ventricles, are electrically insulated from each other where the valves separate the upper and lower chambers. Electricity can only reach the lower chambers through a special conducting system called the AV node that delays the electrical impulse briefly to permit enough time for blood to flow efficiently from the atria to the ventricles before the lower chambers contract. Obviously, this is all a delicate and precisely timed process, and it happens 50, 60, or more than 90 times a minute, depending on your activity level.
When the electrical impulses become disorganized, it results in a loss of organized contraction of the atrium. This is called atrial fibrillation. The atrial muscle stops contracting and begins quivering, known medically as fibrillating, which results in the atria no longer pumping blood into the ventricles. This results in highly irregular contraction of the ventricles, which can cause an uncomfortable sensation. This results in 2 mechanical problems. The lack of coordination between the atria and ventricles diminishes the effectiveness of moving blood with each heartbeat. This may make you feel fatigued or short of breath. Blood in the atria becomes stagnant, which can lead to the formation of blood clots. These can dislodge and go to the brain and cause a stroke or other problems.
So, what causes atrial fibrillation? It arises most often from abnormal rapid electrical firing in one or more of the 4 pulmonary veins that return blood from the lungs to the left atrium. If this irregular firing occurs intermittently, you may have intermittent symptoms. The more frequently and prolonged the intermittent bouts of atrial fibrillation are, the more likely they are to become continuous. You may then be in atrial fibrillation constantly.
There are several aspects to the treatment of atrial fibrillation. The first is designed to prevent the blood clots that can lead to strokes. The most significant risk factors for the development of clots that can cause a stroke or other complication are heart valve abnormality, advanced age over 75, history of congestive heart failure, a history of high blood pressure, diabetes, or prior stroke symptoms. There is only one medication that reduces the risk of strokes or blood clots in patients with significant risk factors, warfarin, also known by its trade name, Coumadin. When no or minimal risk factors are present, aspirin may be sufficient to decrease the risk of stroke. The need for any one of these therapies and their benefits must be weighed against their risks. These must be analyzed on an individual basis and discussed with your doctor.
Another aspect of the treatment of atrial fibrillation is the need to reduce the symptoms caused by the rhythm abnormality. While getting rid of the atrial fibrillation might seem ideal, it is not always possible or necessary based on symptoms and associated medical conditions. Sometimes it is more desirable to control the heart rate alone rather than trying to correct the atrial fibrillation. This is true when the patient has no symptoms at a time when the heart rate is normal. There are many patients who have absolutely no awareness of atrial fibrillation's existence, while others feel miserable. If you and your doctor decide to correct the rhythm, the easiest way to do so is to apply a shock to the chest to restore the heart's normal rhythm. While this stops atrial fibrillation, the underlying condition that caused it to start is not corrected. Therefore, the atrial fibrillation can recur. Certain potent medications can be used to help restore the heart rhythm back to normal or delay atrial fibrillation's recurrence.
Sometimes, when electrical cardioversions or medications are not effective, invasive procedures are required. The first surgery, called the Mays procedure, was very effective in controlling the arrhythmia, but involved open heart surgery and was very difficult to perform. More recently, other less extensive surgical procedures that are not quite as far-reaching or successful as the Mays procedure are at different stages of development.
The most commonly used approach for the invasive treatment of atrial fibrillation at this time is called catheter ablation, which is based on the same mechanism used in the surgical Mays procedure, but does not involve open heart surgery. Instead, a less invasive procedure is performed.
Catheter ablations are performed by electrophysiologists in a highly specialized laboratory. There, we place multiple catheters, thin plastic flexible wires that look like very long spaghetti, into the heart from the legs.
These wires help locate the origin of the atrial fibrillation and permit the application of electrical or freezing energy to the heart tissue called ablation. And this blocks the transmission of abnormal electrical impulses. This creates scarred tissue. Since scarred tissue in the heart does not conduct electricity, it forms barriers to electrical conduction. Since the trigger of atrial fibrillation is most often in one or more of the 4 pulmonary veins, and we cannot generally identify which of these serve as triggers, we ablate the tissue around all 4 of the veins to the left atrium. This eliminates the ability of the electrical impulses to disturb the heart rhythm. To be successful, these ablation-created scars must fully encircle each pulmonary vein where the electrical impulses originate. Not only do they have to encircle it, they must extend through the full thickness of the tissue in order to stop conduction. Otherwise, the abnormal triggers can continue to disturb the heart rhythm.
We have performed thousands of catheter ablation procedures and treated hundreds of patients suffering from atrial fibrillation with ablation.
When cardioversions or medications aren't effective, catheter ablation rarely is the best approach in some patients.
As you consider your options for treatment, you are bound to have more questions, and we will do our best to answer them. In the meantime, we hope you found this introduction helpful. Thank you.